Hi, ma'am. Good evening. Ma'am, your voice is not audible.
Shall I share my screen?
Yes, ma'am.
Okay. Yeah, so we can start.
Ma'am, slides.
Okay, yeah. Just a minute. Just give me 2 minutes.
Okay, ma'am.
Shall we start?
Yes, ma'am.
Okay. Hello everyone. So in this lecture we are going to discuss genitourinary part 4. And we're going to cover this in, this is a part of our 90-day university pre-final mastery program. And in this program, we're going to rapidly revise all important topics, volatile facts, and all high-yield topics are going to be covered. We're going to discuss a few long answer questions, short answer questions, and also we're going to discuss a few case-based questions along with few MCQ questions. In Auricle, we have recorded classes, live classes, practical sessions. There is an exam module for rapid revision and also hard copy book sets. The feature of recorded classes comes in very handy for flexible learning and convenient revision. Live classes, we cover in-depth topics along with complete explanation of all small topics, and there is an interactive learning by use of MCQs, Viva, and poll questions, etc. In the express exam module, we cover the syllabus in 20 hours, and all frequently asked questions are going to be covered in this express exam module. There is a one-to-one doubt clearing session. Hard copy notes are there for flexible learning. There is a question bank with various levels of expert level from beginner to expert for FMG as well as NEET PG aspirants and also for your Proff exams. Interactive practical sessions are also there which simulate a hands-on experience. These are the subscription plans which you can go ahead and check in the website, Auricle website. So today's class is the fourth class of our genitourinary pathology, in which we are going to briefly discuss testicular tumors, infertility, and what are the conditions leading to infertility, prostatic hyperplasia, and some related conditions. And most importantly, we are going to discuss testicular tumors in detail. So first of all, we're going to discuss the types of testicular tumor classification, because to go ahead and discuss, we need to know the classification. So testicular tumors are divided into germ cell tumors and stromal tumors. So in germ cell tumors, we have two types of tumors. One is GCNIS related tumor. GCNIS is nothing but germ cell neoplasia in situ. Germ cell neoplasia in situ. So this is GCNIS. Now, this is a precursor lesion. What does precursor mean? Precursor means that this has not developed into a full-fledged tumor yet, but this is still in an early stage. So this is GCNIS, which is a precursor lesion of germ cell tumors. So some tumors are related to GCNIS, some tumors are not related. The tumors which are GCNIS related are seminomas. Seminomas are definitely GCNIS related, and there are certain non-seminomatous tumors such as embryonal carcinoma, post-pubertal yolk sac tumor. Why is this specifically mentioned? Post-pubertal yolk sac tumor. The reason is pre-pubertal yolk sac tumors are also germ cell tumors, but they are not related to GCNS. They do not develop from the same precursor lesion as post-pubertal yolk sac tumors. So that is the main difference. And then choriocarcinoma, which is also a germ cell in situ related lesion. And then post-pubertal teratoma. Here, the most important thing which you have to remember is pre-pubertal yolk sac tumors and pre-pubertal teratomas are not from the same precursor lesion, which is GCNIS, germ cell neoplasia in situ related lesion. Okay, a few other testicular tumors which you have to remember is lyric tumor, Sertoli cell tumor, granulosa cell tumor. Okay, and then we have spermatocytic tumor. So in germ cell tumors, there are these tumors and there are non-GCNS related tumors. 3 tumors are GCNS non-related, which are prepubertal yolk sac tumor, prepubertal teratoma, and spermatocytic tumor. This spermatocytic tumor. So These three tumors. So you could be asked an MCQ question also related to this. They can give you a case of GCNIS and they could ask you that which of these is not arising from this lesion. So be aware that there are three germ cell tumors which are not GCNIS related. And there are a few other germ cell tumors also, which are dermoid cyst, which is a part of teratoma. Okay, so now let's move on. This we have already discussed. How does GCNIS develop? So I told you we'll be discussing more about GCNIS, correct? So from the gonocyte, what is going to happen is because of some environmental factors or even genetic factors, the gonocyte development is going to be delayed. Okay, because of this delay and reorganization of the testis, there is going to be proliferation. GCNIS is nothing but an in situ lesion. Okay, whenever we talk about an in situ lesion, it means that it has not reached the basement membrane and it is not going through the basement membrane and coming out to the stroma. So when you call it a carcinoma, it should come into the stroma. So when the basement membrane is intact, then it is an in situ lesion. You can remember we discussed in breast that there was a ductal carcinoma in situ. So similarly, there is a germ cell neoplasia in situ. These are all testicular tumors, right? So what is there inside the testis? They're going to be germ cells. So these are all germ cells. And these germ cells are proliferating and there is atypia in the germ cells. But the basement membrane here is intact. It is not coming out and it is not spreading all over. So in that case, this is a germ cell neoplasia in situ. So when this proliferates and this comes out, then you have germ cell neoplasia in situ related regions, germ cell tumors. Okay, so we have seminomas and non-seminomas and also teratomas. We know that prepubertal anything teratoma or prepubertal yolk sac tumor is going to be not developing through this pathway. Okay, so this is one thing which you have to remember. So now we'll discuss each and every testicular tumor. First and foremost, the most common tumor of the testis is seminoma. And seminoma has a genetic predisposition, and we saw it was related to germ cell neoplasia in situ, and then cryptorchid testis. Seminomas usually arise in cryptorchid testis. So what is cryptorchidism? Usually in embryonal stage, you must have read in your anatomy that testes are present in the abdominal cavity. Right? During the embryonal stage, they are present in abdominal cavity. And during development, testes slowly descend and they come into the testicular sac. So this descendance of testis does not happen in certain conditions which will lead to cryptorchidism. That means the testis does not descend into the testicular sac. So in that case, testis will remain in the abdomen and this is known as cryptorchidism. So what is the morphology of seminomas? When on cut section, we are going to see gray-white lobulated mass. You can see this is gray-white. There are so many gray-white areas and there are lots of lobulations over here. So this is a gray-white lobulated mass. This is very classic of seminoma. Microscopically, I want to show you something interesting. Here you can see that these are all cells. Right, these are all cells with very clear cytoplasm and small nucleus over here. And you can see the germ cell GCNIS cells totally resemble the cells of seminoma. Right, so they resemble the cells of seminoma here. And there is going to be uniform sheets with clear cells and these sheets are going to have lymphocytes. So this is an important feature of seminoma. Uniform cells with clear cytoplasm along with septae with lymphocytes. So this is a very important feature of seminoma. And we know this testicular mass is painless and metastasis can occur in very later stage. Classic of seminoma, they can give you this image, so you can remember it. Okay, so we had discussed seminoma, which was a short answer question. And then we're going to discuss some role of tumor markers in testicular tumors. So I'm going to quickly summarize a few tumor markers which are commonly can be asked. So first is PLAP, PLAP. PLAP is nothing but placental alkaline phosphatase. So placental alkaline phosphatase can be positive in seminomas. You can write this in the short note of seminoma as well, that we're going to have placental alkaline phosphatase positivity. And then what is going to happen is you can have something called lactate dehydrogenase, LDH. LDH positivity you can see in also is positive in seminomas. LDH positivity will also be seen in seminomas. Okay. So the other tumor marker which you have to remember is AFP. AFP is alpha fetoprotein. Okay. Alpha fetoprotein is usually positive in embryo. Alpha fetoprotein is usually positive in yolk sac tumor. Okay, alpha fetoprotein is positive in yolk sac tumor. So these are the three important tumor markers which can be asked for your germ cell tumors. And another one most important tumor marker is HCG. HCG will be positive in choriocarcinoma. HCG we know is a marker of pregnancy. So choriocarcinoma is a carcinoma which has cells like syncytial trophoblasts and cytotrophoblasts. So these are the cells which proliferate during pregnancy. So this choriocarcinoma is going to produce HCG, and hence in serum increased levels of HCG will be seen in choriocarcinoma. So these are the few tumor markers which you have to remember. Why is this important? Why do you have to know these tumor markers? These tumor markers are useful in the diagnosis of these tumors. These tumor markers are helpful in prognosis, because once chemotherapy is started, once surgery is started, then we monitor these tumor markers to see if these tumor marker levels have gone down or not for monitoring treatment. So these are the things we have to remember. PLAP for seminoma, NDH for seminoma, AFP for yolk sac tumor, and HCG for choriocarcinoma. So the next short answer question which we have to discuss here is cryptorchidism. Cryptorchidism, as I already said, is undescended testis. Okay. So why does testis not descend into the testicular sac? Some of the reasons are hormonal factors. One could be anatomic obstruction. There could be obstruction in the area where it is descending. So it's somewhere stuck inside the abdominal cavity. So these could be the reasons. So one of the most important reasons which we said, what is the risk that if a cryptorchid testis is there, okay, the function is going to be normal, because most of the times only one testis is not going to descend. So one testis is descending and one testis is cryptorchid. So this is what usually happens. So what will happen is the function is going to be normal, but the cryptorchid testis, what happens in the cryptorchid testis is it is going to, the risk of GCNIS is going to increase in the cryptorchid testis. Okay, so because increase of GCNIS is there in the cryptorchid testis, you are going to have increased risk of seminoma. Okay. Other than that, another thing which can happen in this cryptorchid testis is, you know, the cord, the spermatic cord is going to get twisted, and this can result in testicular torsion. Okay. This can result in testicular torsion in the cryptorchid testis. So one is risk of seminoma, and then we have risk of testicular torsion, and then we have increased risk of infertility, because cryptorchid testis is not going to be functional and it is not going to be producing testosterone as much as the normal testis. So because of this, it leads to infertility, risk of infertility. So these are the risks of cryptorchid testis. Now we know what cryptorchid testis is, why it happens, and also what are the risk factors of, what are the risks of having a cryptorchid testis. Okay. So now we'll go ahead and discuss other few questions, short answer questions. So male factor, what are the causes of male infertility? So what could be the causes of male infertility? We have hormonal causes, we have anatomic abnormalities. So we know that there is a spermatic cord, and then there is a spermatic cord which is attached to the testis, and then we have vas deferens. So, and we know sperm is produced, and then there is epididymis. So, the sperm travels through these and then stored in the testis. So that's what happens. So, what could cause infertility? First of all, the hormone producing sperm is not adequately produced. So that is one hormonal causes. Second is that wherever the sperm is traveling, there is a abnormality or there is a blockage. So in that case, there could be abnormality. So anatomic abnormality in the vas deferens or in the spermatic cord. So that could be a reason. Another reason could be infections like sexually transmitted infections or even infections like orchitis. Okay, sometimes we know that mumps virus is an important cause of orchitis in children. So that could be a reason of male infertility. Lifestyle factors are also important like smoking and alcohol. And also we have genetic causes such as Klinefelter syndrome. To recall your genetics, Klinefelter syndrome is a genetic disease with 2X and Y. So ironically, if 2X chromosomes are there, so there is decreased testosterone production, and these patients are also increasingly susceptible to cryptorchid testis. Okay. So because of that, there is high chances of infertility in these patients. Okay. Now we've already discussed significant amount about germ cell tumors of the testis. We'll just give you an overview so that it is you can recall it very easily in your exams. So we have seminomatous tumors. We've already discussed that germ cell tumors of the testis. We have two types of germ cells of tumors. One is one of the tumors which arises from GCNIS, and another type of tumor which is non-GCNIS arising tumors. Okay, you have to make this chart whenever you are asked germ cell tumors. So what are the tumors which are non-GCNIS? Just remember 3 tumors which are non-GCNIS. Rest of the other germ cell tumors are going to be GCNIS. What are the 3 tumors which are non-GCNIS? Prepubertal, both prepubertal yolk sac tumor as well as prepubertal teratomas. Both are non-GCNIS associated tumors. And then another one is spermatocytic tumor. Okay, spermatocytic tumor. So you just remember these 3 tumors. All other germ cell tumors are going to be arising from GCNIS only. So this is a so we have prepubertal type teratoma, which is not arising from the GCNIS. Again, prepubertal yolk sac tumors, spermatocytic tumors. So these 3 are separated. GCNIS, whatever tumors come from the GCNIS, seminoma, most commonly asked in the exam also. So seminoma. And the second one is embryonal carcinoma. Embryonal carcinoma. We know prepubertal type teratomas and prepubertal type yolk sac tumor were not GCNIS associated. So postpubertal are GCNIS associated. Also choriocarcinoma is GCNIS associated. So these are this is the classification of germ cell tumor. Now you know what GCNIS is also. It is germ cell neoplasia in situ. Okay, so this is what GCNIS is. Now I'll tell you a few markers which are associated with these tumors. Okay, so every tumor which is GCNIS associated, it is going to have a few markers in common because the tissue which starts, that is the precursor tissue, is the same. So SAL4 is going to be common in all these tumors. As you can see here, SAL4 is there in seminoma, GCNIS associated, SAL4. So everywhere you will see SAL4. Okay, and a few markers are there which are unique to each disease. So seminoma we have flap. As we already discussed, flap is a serum marker also. It can be tested in the serum also, or it can be done in the tissue as an immunohistochemistry also. Okay, what is immunohistochemistry? Usually what we do is that this antigen is going to be present in the tissue, and we are going to induce an antibody, and then we are going to give a chromogen which is going to give color, and in the stain it will appear colorful so that we can see it under a microscopic slide. So this is what happens in immunohistochemistry. Flap is a unique marker which is positive in seminoma. Also remember CPT is positive in seminoma. Okay. And similarly, yolk sac tumor is positive for glypican 3. And embryonal carcinoma is positive for CD30. You don't have to remember all these markers, just one marker for each. So if you get a case, you can identify which marker it is. Maybe they will give you a marker or a serum marker or a immunohistochemistry marker. So just remember single marker. Salfo common for all germ cell tumors. Okay, flap, CKIT, seminoma, and then yolk sac tumor, glypican 3, embryonal carcinoma, CD30, choriocarcinoma, HCG. That is it. Nothing else you have to remember. Negative markers for the pictures. Forget it. Teratomas will be positive for cytokeratins because what is teratoma? Teratoma is nothing but it is a tumor tissue, but it has abnormal tissue from all other embryonal layers. For example, you will have epidermal, you will have skin in that, you will have neural tissue, you will have cartilage, you will have bone. You have seen teratoma gross that we have hairs in it and it can have calcification, so it can have any tissue in that. So there is no specific serum marker or no specific marker for teratoma as such. So this is for immature, this is for teratoma. Teratomas can further be classified into mature and immature. Okay. How will you know if the teratoma is mature or immature? If the teratoma has immature neural elements, okay, then the teratoma is immature. Otherwise, if it does not have any immature neural elements, then it is going to be a mature teratoma. So this is how you know if the teratoma is mature or immature teratoma. Now we'll see benign prostatic nodular hyperplasia. This is also one of the questions which was asked. So we are going to see the etiopathogenesis of benign prostatic nodular hyperplasia. Now let's just take a second and decode this name. The name says benign. There is prostatic tissue nodular hyperplasia. So there is hyperplasia of the prostatic tissue. It is benign, not malignant. Okay. So this is the simple decoding of this. You can easily extrapolate. So why does this happen? Because of certain hormones. For example, dihydrotestosterone. We'll see how that happens in a while. So morphologically, you have nodular hyperplasia of stromal as well as glandular tissue. So in prostate tissue, you're going to have glands and surrounding stroma. So hyperplasia, in this hyperplasia, you're going to have hyperplasia of this gland as well as stromal tissue. So what is the clinical feature? Usually, this is the prostate. Okay. Prostate has, you have urinary obstruction. So when the prostate gets hyperplasia, usually what happens is the ureter travels from the center of the prostate like this into the bladder. Okay, so here is where the central zone is. There is a central zone here and there is a transitional zone. Okay, so usually in the central zone is where your BPH happens. So when this area is hyperplasia happens, it's going to somewhere compress the ureter, and when it compresses the ureter, you're going to have urinary obstruction, and because of this, you're going to have increased urinary frequency because there is delayed bladder emptying. Okay, from the bladder, you're going to have delayed bladder emptying, and because of that, you are going to have increased urinary frequency. So these are the symptoms of BPH. Now, how does BPH happen? So this is the first. Let's discuss the normal cell and then the cell in which BPH happens. So testosterone is going to act on the androgen receptor in the cell, and then it is going to produce growth factors, right? So this is what is going to happen in the normal condition. Now there is a enzyme known as 5-alpha reductase. So what this will do is this is what produces, it converts testosterone into dihydrotestosterone, and dihydrotestosterone is the active form of testosterone. This is what will actively go and act in the androgen receptor and induce growth factors. So what happens is there is increased 5-alpha reductase in this condition. So when 5-alpha reductase is more, it is going to convert more and more testosterone into dihydrotestosterone. This process is going to happen. And ultimately, dihydrotestosterone will stimulate the androgen receptor. As we know, androgen receptor is again a nuclear receptor, which will induce the formation of growth factors. So growth factors will increase proliferation of tissue, which will again result in hyperplasia. So that is what happens here. Okay, you can see here there is hyperplasia of the benign glands as well as the stroma. Okay, there are lots of cells here. So this is what happens. So now imagine how would you control this? You would have to inhibit some enzyme. Which enzyme will you inhibit? You will inhibit 5-alpha reductase 2. So that is what we have. The drugs which are used for prostatic hyperplasia are nothing but dihydrotestosterone inhibitors or 5-alpha reductase inhibitors is what you will be reading this in pharmacology also. So this is what is the pathophysiology, and this is how benign prostatic hyperplasia looks like. Okay. Now again we have discussed a few markers, but again these are a few markers, very important markers. They can be asked again and again. So I just included this just for a review purpose. So we have alpha fetoprotein. I already told you in which tumor alpha fetoprotein arises, right? It is yolk sac tumor. Okay, and also there is one other important feature which you have to remember in your yolk sac tumor, which is nothing but this. You can see this over here. These are glomeruloid shaped bodies. You can see that this somehow resembles a glomerulus and glomeruloid shaped body, and there's a central vessel over here. These bodies are present in yolk sac tumor. These bodies are nothing but Schiller dual bodies. These are glomeruloid shaped bodies in which you have a central blood vessel. So these are Schiller dual bodies of yolk sac tumor. And human chorionic gonadotropin is increased in which tumor? Choriocarcinoma. Okay, choriocarcinoma. Choriocarcinoma, chorio. Chorio you can relate it with pregnancy. So HCC also pregnancy, human chorionic gonadotropin, choriocarcinoma. This is the easiest to remember. And then lactate dehydrogenase and also FLAP, which tumor? Seminoma. Okay. Next. Then this is a short note on human chorionic gonadotropin. This is a marker for testicular tumor, which is fine. Also, one more important point I would like to tell you is almost 15% of seminomas can also have increased HCG. So it's not only chorionic carcinoma, but also a few percentage of seminomas can have increased human chorionic gonadotropin. Okay, so these are elevated in choriocarcinomas and some seminomas. Okay, this has diagnostic as well as prognostic relevance. Also, always remember all these markers have diagnostic relevance, but also prognostic relevance also, because after therapy they are continuously monitored to see if the tumor has regressed or not. So it has prognostic relevance also. Now seminoma we've already discussed, but always remember seminoma is most commonly asked. So you will have to remember that the classic histopathologic feature of seminoma with clear cytoplasm and a fibrous septae which has lymphocytes. Fibrous septae will have lymphocytes in seminoma. Okay, this is the image which you can see here. See, there is a tumor cells over here, and this fibrous septate has small cells. So these are lymphocytes. So this is very classic for seminoma. Also, the gross is very classic for seminoma, white with small globules. Next short answer question is condyloma acuminata. This is a benign lesion caused by HPV infection. Okay, which HPV infection is implicated? Which HPV? 6 and 11. Okay, benign HPV 6 and 11 is implicated in the formation of condyloma accumulatum. These are also known as benign warts. Their papillary growth, they are papillary, and this papillary growth, you can see them in histopathology. See, same papillary growth pattern, like this. Okay, these are papillary. And in this context, I would like to tell you, these are benign HPV infection causing viruses. There are some high risk HPV infection viruses. HPV, these are a very low risk because condyloma accumulatum is not going to convert into carcinoma. But there are high risk HPV viruses. Remember, high risk HPV viruses are 16, 18, and 33. Just there are more, but for now, remember 16, 18, and 33 are high risk HPV viruses. 6 and 11 are benign HPV viruses. And you see there is papillary growth pattern in condyloma accumulatum. Okay, all. And whenever you have a HPV infection, you will have something known as polycytosis. Polycytosis is you have a nucleus here. There is a cytoplasm. Surrounding the nucleus, there is a clearing. Okay, there is a clearing. There is a clear area. Apart from that, the nucleus is hyperchromatic and irregular. You can see here, now I show you a normal cell and a polycyte over here. Here you can see that this is a normal cell. This here is a normal cell. There is a nucleus, there is a cytoplasm. Nucleus is almost purplish in color, cytoplasm is pink in color. There is no clearing around the cytoplasm, around the nucleus. So this is a normal cell. But see this cell here. This nucleus is dark. This nucleus is dark when compared to the nucleus here. So dark nucleus surrounding the nucleus, you can see a clear area, white colored area. This is a polycyte. So in any HPV infection, you will see this polycyte. This cell is known as a polycyte. Okay, so polycyte is seen in HPV infection. So it's a result of HPV infection. So the nice contrast you can see here, normal cell versus a polycyte. Now, next one, granulomatous prostatitis. Again, a short answer question. Okay, we know that prostatitis, okay, itself, itis means inflammation, and granuloma, you know, granulomatous prostatitis, granuloma formation will occur in granulomatous prostatitis. So, what are the causes? That is very important. We know infectious tuberculosis, fungal infection, sarcoidosis. These are common causes of granuloma, right? So these will cause granuloma. But other prostate, very important, which you have to remember, is BCG induced prostatitis. There are certain tumors where BCG can be given to reduce the effect. Okay, certain bladder tumors BCG can be given as treatment. So as an effect, BCG induced granulomas can be seen in the prostate. So that is one important reason. Another thing is non-specific granulomas, which can also be seen in the prostate because certain ducts, they rupture and the surrounding areas, macrophages and inflammatory cells come in and they produce a granulomatous reaction surrounding the ruptured duct or ruptured gland. So these are three important causes of granulomatous prostatitis. One is infectious. We all know that tuberculosis will cause case-eating granulomas, and granulomatous infection can be caused in the prostate. Other than that, BCG-induced and non-specific prostatitis are also common in prostate. Okay, morphology of granuloma formation we know, but I'll just quickly revise. First of all, we have central case-eating necrosis if it is a tubercular granuloma, and then surrounding we'll have histiocytes, epithelioid histiocytes, which are slipper-shaped cells. Okay, so there are slipper-shaped epithelioid histiocytes surrounding the central caseous necrosis. Not every granuloma will have central caseous necrosis, but this is a tubercular granuloma which is going to have a central caseous necrosis. And then the most important types of cells which we are going to see are the Langhans type giant cells, which have peripherally placed horseshoe-shaped nucleus. So these are Langhans type giant cells. Okay. Apart from this, what will we have? We will have some lymphocytes. We will have some lymphocytes and plasma cells. So what are the components of this granuloma? We're going to have epithelioid histiocytes, okay, giant cells. In tubercular, maybe mostly it is Langhans type giant cells, necrosis, lymphocytes, and plasma cells. So these are what you will see in a granuloma, okay. You can see here that these are all whatever I had drawn here. So these are the small slender cells here. These are nothing but the epithelioid histiocytes, and this large cell, this is a giant cell. Okay, so this is a representation of a granuloma. Now we'll discuss a certain case-based questions and a few MCQs, and we'll wrap this session up. So we have a 35-year-old man who presents with a painless enlargement of right testicle. So there is painless enlargement of right testicle. Ultrasound reveals a homogeneous mass. Okay, homogeneous mass is there. So it's a tumor for sure. Serum markers show mildly elevated LDH but normal AFP. What does normal AFP say? That it is not a yolk sac tumor. Because we discussed if AFP is there, it's yolk sac tumor. And then HCG levels normal. What does it say? It's not a choriocarcinoma. Okay. So what is the likely diagnosis? Elevated LDH, what should you think of? You should think of seminoma. And also, what else is elevated in seminoma? Flap. Okay. Describe morphological features which you expect. Now, let's go back and let's see the image for. So you can see here that there is a homogeneous mass, gray white, and it has small lobules. So what you have to write grossly is gray white homogeneous lobulated mass. Okay. And microscopy, we have already discussed that there are sheets of uniform cells with clear cytoplasm along with fibrous septae. These fibrous septae, what will they have? They will be infiltrated by lymphocytes. So these are the classic features of seminoma. Okay, so next question. Next is another case-based question. A 2-year-old boy presents with undescended testis, which was noted since his birth. His parents are concerned about potential complications. So we have already discussed undescended testis complications, right? So what are the possible causes? We have already discussed that too. There are hormonal causes of undescended testis. There could be anatomic obstruction of undescended testis. So these are the possible causes of undescended testis. Also, there could be genetic diseases like Klinefelter syndrome, which can result in undescended testis. What are the associated risks if it's left untreated? Most important, we discussed that in undescended testis or in a cryptorchid testis, we are going to develop GCNIS. So if GCNIS develop, which tumor can commonly develop in GCNIS? Seminoma. So in any patient with undescended testis, in a cryptorchid testis, seminoma is very likely to develop. Other than that, we saw increased risk of torsion, increased risk of infertility. Okay, so these are the complications of undescended testis. Okay, done. Now we'll discuss some case-based MCQs. First, this question says a 32-year-old man is there presented with painless swelling in his left testicle. He has a well-circumscribed homogeneous mass. Everything is fine. CM study shows normal AFP and mildly elevated HCG. Now this is a trick question for you. Okay. Now this question is truly very tricky because they have given you increased HCG, normal AFP. Okay. But they have given you a homogeneous mass, which is seminoma with like mass. So here is where that comes into play. Elevated HCG will be seen in which one? It will be seen in choriocarcinoma, right? But choriocarcinoma usually does not have a homogeneous mass. You're going to have a hemorrhagic necrotic mass. Okay, but here you have elevated HCG. So I told you that in 15% of seminomas, you will have elevated HCG. So this is still a seminoma, but they've not given you classic flap or LDH. But they've given you homogeneous circumscribed mass, which is not seen in choriocarcinoma. You see a hemorrhagic necrotic, not very well circumscribed mass in choriocarcinoma. So this answer here is seminoma. Be aware of these questions. And then you have another question where a 25-year-old male with a history of cryptorchidism is diagnosed with a testicular mass. Serum tumor markers show elevated AFP and HCG. Okay, so again, AFP and HCG are elevated. What was there in question? Normal HCG and AFP. Okay, so this is a patient with cryptorchidism, and this patient has elevated AFP and HCG. So this would be, now this is again a very tricky question which they have asked. So now we have elevated AFP. Okay, and we have elevated HCG also. Now AFP is elevated in which tumor? Yolk sac tumor. HCG is elevated in which tumor? Choriocarcinoma. So do we have yolk sac tumor here? We do not have yolk sac tumor. We do not have choriocarcinoma. Is this seminoma? No. Why? Because AFP is not elevated in seminoma. Is this teratoma? No. Because teratoma has normal serum markers. Every marker is normal in teratoma. Now, choriocarcinoma, could it be? It could not be, because AFP will not be elevated in choriocarcinoma. This tumor here is a mixed germ cell tumor. So this is a germ cell tumor. Both yolk sac and choriocarcinoma, both are germ cell tumors. So in this case, both AFP and HCG are elevated. So this is a mixed germ cell tumor. Okay. So let's discuss the last case-based MCQ. This is a 3-year-old boy who is evaluated for undescended testicle. His physical exam shows an empty right scrotum. What does empty right scrotum suggest? It is a cryptorchid testis, right? So cryptorchid testis or a undescended testis here. Abdominal testis. Okay, undescended testis. And his parents are concerned about long-term risks. Which of the following is a potential long-term risk associated with this condition? Now let's just read through these options. We have increased risk of testicular torsion. We know testicular torsion risk is increased. Increased risk of prostate cancer. No. In cryptorchid testis, we do not have increased risk of prostate cancer. Infertility, we saw the risk of infertility was increasing, and the risk of testicular cancer was increasing, especially germ cell tumors, and most commonly seminoma. So this is also not right. This is also not right. Here the correct answer is increases for testicular torsion. Why? Because the spermatic cord will get twisted and there is increased chances of testicular torsion in cryptorchid testis. So that is all for today's class. Thank you. Let's see in another class soon.